Hi everyone, welcome to Dr. Deepa's Learning Lounge. I am Dr. Deepa and today we will discuss one important topic which is congenital megaloblastic anemia. It is very often that we see megaloblastics change in the peripheral smear. There are a lot of smears we get I think most of us see at least one megaloblastic anemia case when we are looking at the bone marrow, or at least one peripheral smear which has macrocytic blood picture. But do we all even keep our eyes open to look at congenital megaloblastic anemia? That is also a diagnosis that is quite possible, but it is missed out in your routine hectic workload. So if you have a patient whom the clinician has told you that he has supplemented adequate folate and B12 and he still doesn't see much improvement in the peripheral smear, or you know that the patient's level of B12 and folate is normal and still you're seeing a megaloblastic change in the peripheral smear, you need to think of the congenital clauses. So without much ado, let's just go through the PowerPoint so that it'll be easy for you guys to understand and keep your eyes open for this disorder. So, let's just look at congenital megaloblastic anemia, which is a rare and complex group of disorder where many people are not familiar with it. So the goal of this presentation is to break down the aspects of CMA so that it is easy for you to understand and manage it, because this is a collaborative interdisciplinary diagnosis. So this is what usually a peripheral smear will look like to you, that you will see these hypersegmented neutrophils and you will see these macrocytes and macrovellocytes in your peripheral blood. That is when you have to consider to try and diagnose the congenital form of megaloblastic anemia also. So what exactly are we thinking about when we are talking about the congenital megaloblastic anemia? So let's just define what we are talking about. So the congenital megaloblastic anemia is basically a form of megaloblastic anemia which is related to a couple of inherited disorders, and these defects mainly are related to how the body absorbs and uses these two critical vitamins, which is vitamin B12 and the folate. So it's important to understand that congenital megaloblastic anemia isn't a single disease, but it is a blood-related symptom that is highly heterogeneous and there are complex genetic disorders associated with it. So each disorder affects a different component of the complex biochemical pathway of the vitamin B12 and the folate metabolism. And the critical diagnostic point is to remember that you cannot rule out or rule in CMA just because the patient is having a normal B12 or a folate. So this is because many inherited defects involve the body's inability to utilize substances properly, even if they are present in sufficient amounts. So what is the role of B12 and folate in the DNA synthesis? To understand this deficiency as a cause of anemia, we need to quickly review the biochemical pathway to ensure that we have enough folate in the correct form to produce the building blocks of the DNA. So this is a short picture in which you are able to see the gastric parietal cells, the entire pathway of B12 and folate, right from the gastric parietal cell to the marrow cell. This is the pathway that we are all familiar with. So as we know, folate is absolutely necessary for making the purines and the pyrimidines. The critical step is conversion of the precursor molecule, which is deoxyuridine monophosphate, to deoxythymidylate. So this process of conversion of deoxyuridine monophosphate to deoxythymidylate and a defective tetrahydrofolate is something that will affect the pathway. As you all know, that the deoxythymidylate is a derivative of tetrahydrofolate, which is the only carbon donor for this entire reaction. So now this is where the cobalamin comes into play. The body's pool of active tetrahydrofolate is basically replenished through a reaction that requires cobalamin as a cofactor. So why do you need cobalamin as cofactor? It is specifically required as methylcobalamin to convert homocysteine into methionine. So this is where methylcobalamin works. So homocysteine is converted to methionine, and in doing so, it makes the methyl group of 5-hydroxy tetrahydrofolate tetrahydrofolate, which regenerates the active tetrahydrofolate form. So when there is a lack of either vitamins, essentially this jams up this critical process of synthesis and replenishment of tetrahydrofolate, and this impairs the DNA synthesis. The end result will be a megaloblastic anemia where the RBC precursors of the bone marrow have impaired nuclear maturation relative to the cytoplasm. So the cytoplasm is huge and the nuclei are hypermature. So this is what explains what we see in the biochemical marker in relation to any of these vitamin deficiency. Also in a folate deficiency, the only impact in this is in the step 1. So when there is only one impact in the step 1, so we see only elevated homocysteine as a biochemical marker. But in cobalamin, because it impairs also the second reaction that converts methylmalonyl CoA to succinyl CoA, we see both elevated homocysteine levels and an elevated methylmalonic acid. So that is primarily the difference in the biochemical markers between these two processes. Just please look at these images, take a screenshot and store it for your future. So what is so to summarize what we just spoke about in the pathway, folate is essential for one, producing purines and pyrimidines, which are the building blocks of DNA. First point. Second, where is the bottleneck? The rate limiting step is the specific derivative of tetrahydrofolate and the replenishment of the tetrahydrofolate. Where is the cobalamin leak? The cobalamin is a cofactor that is needed to convert 5-methyl tetrahydroxyfolate back into tetrahydroxyfolate. And the deficiency of either folate or cobalamin impairs the crucial step of DNA synthesis and ultimately results in megaloblastic anemia. So what are the biochemical markers? Like I already said, folate deficiency, there is only a elevated homocysteine because the first step is impaired, while in cobalamin deficiency, there is an elevated homocysteine and malanoic acid. All right. So the next is, how do you classify this genetic disorder? So the classification of this genetic disorder requires numerous deficiencies to be considered that can be grouped based on where they affect. First, we have defects of the cobalamin absorption. So this includes conditions like intrinsic factor deficiency, and which is sometimes called congenital pernicious anemia. So this and Emerson-Grasbeck syndrome, these are the two defects, and Emerson-Grasbeck syndrome is characterized by a defective intestinal reabsorption. A key clue for this disorder is that patients also have proteinuria. The largest group of these disorders, however, are the ones that impair the utilization of cobalamin, and these are often abbreviated as SIBIL group, as SIBIL group name. And we can categorize them based on which are the two key cobalamin derivatives that are affected. Some disorders like SIBIL type C, some disorders like SIBIL type C affect the processing of the cobalamin early on. So both the methylcobalamin and adenosylcobalamin pathways are basically impaired. So these patients present with both homocystinuria and methylmalonic acidemia. The SIBIL C is most common symptom of intracellular cobalamin disorder. The other disorders like SIBIL E and SIBIL G only affect the methylmalonic cobalamin pathway. So these patients will have homocystinuria, and adenosylcobalamin synthesis is normal. It's important also to note that the defects in the adenosylcobalamin pathway also can occur. So when there is a defect in adenosylcobalamin pathway such as SIBIL A and SIBIL B, these cause only methylmalonic acidemia because this pathway does not affect the folate metabolism. So these patients do not have megaloblastic anemia at all. Finally, there are defects of the folate metabolism like hereditary folate malabsorption defects. So these are other rare syndromes such as thiamine responsive megaloblastic anemia and orotic aciduria also. So these are all the various genetic defects that needs to be kept in mind when you're thinking about congenital megaloblastic anemia. So I know it's a long list, but you have to be aware of this and you have to look for these genetic disorders, especially if you have unresponsive patients to vitamin supplements. So, what is the clinical diagnosis and what are the clinical clues? The clinical presentation of congenital megaloblastic anemia can be quite variable in the sense although this condition affects the blood, megaloblastic anemia is often not the first sign. The clinician's attention is grabbed by the genetic disorder where there is severe anemia, megaloblastic change and neurological defects. The patient often has failure to thrive and developmental delays and seizures and metabolic acidosis, and the blood picture is usually subsidiary to this existing diagnosis. So microscopically, however, the features are very characteristic of megaloblastic anemia regardless the cause, and on a peripheral blood smear we see hypersegmented neutrophils, large oval shaped RBCs which are called oval macrocytes, and the mean corpuscular volume, as all of us know, is way above 120 femtoliters. So the bone marrow again is a telltale sign where in the bone marrow you will be able to see high cellularity with increased number of RBC precursors, which is a phenomenon called as what? Erythroid hyperplasia. So this is again characteristic of megaloblastic anemia, and the diagnostic process basically involves a stepwise pattern. First and the most important step is to rule out an acquired cause of B12 or folate deficiency. That is the first step. And this is vastly more common. So first, rule out the acquired deficiency. Even in a young child, the dietary issues can occur and the acquired factors should be ruled out. After the initial workup suggests that the acquired disorder is ruled out, then the workup is to look for a congenital issue, and the next step is to perform the biochemical assays. Particularly, what do you look at? The plasma homocysteine and urine methyl malanoic acid. So these levels in combination can point to a pathway of which pathway is affected, whether it's the step 1 where folate alone or step 2 where B12 can affect step 1 and step 2. Finally, based on the biochemical clues, we can proceed to a targeted genetic testing. So for this disorder, which affects the intracellular cobalamin, sequencing of the MMAHC gene is often pursued, which is the most common mutation. So I already told you the different mutations and different pathways that can get affected. So you need to keep your eyes open for any of these. So it's very important that you see through this as a stepwise process, rule out the acquired first, then think about the congenital in a stepwise pattern. Okay. So, to summarize, what I am telling you as a key part of this presentation is that congenital megaloblastic anemia is rare, but you need to think about it in case of unresponsive patients. Firstly, the microscopic findings in the blood and the bone marrow are a huge clue, definitely, but they are not specific. You can tell the difference. You cannot tell the difference between a congenital and an acquired megaloblastic anemia looking at the bone marrow or the smear. It's not possible. So what do you have to do? The second and important thing is to remember that normal serum B12 and folate are a clue, but they do not rule in or rule out the disease again. The third and the most helpful is the biochemical clues, that is elevated plasma homocysteine and methyl malanoic acid levels. Finally, the diagnosis of congenital megaloblastic anemia is not at all a one-step process. Because of its intricate nature of biochemical diagnosis, the classification demands a high level of expertise. In the sense, you need to look at different specialists working to hand in hand. You need to look at the histopathologist, the hematologist, clinical geneticist, and biochemical geneticist and biochemist. All of them together only can diagnose a congenital megaloblastic anemia. So thank you so much for your attention. Stay tuned to www.drdeepa's Learning Launch for many more such lectures. All the best.